Welcome to the virtual family council meeting, everyone. My name is Jamie Rose. I am your virtual meeting coordinator. We're going to start off our meeting with our confidentiality reminder. Please refrain from using the name of your loved one. Do not name specific facilities. Please use a nursing home or the personal care home to present to the group. If you need specific assistance, please use the chat feature to state which county you're in, and we will get you connected to your assigned ombudsman. And remember, these calls have public access and are designed for family members and friends of residents in long-term care facilities. So we'll review our meeting agenda. We're going to get our virtual meeting tips from Eliza, and then we'll turn it over to Richard Mollot for assignments and care plans. And then we'll review our upcoming meeting topics. So without further ado, I will turn it over to Eliza for our virtual meeting tips.
Good night, everyone. You guys have all been placed in mute upon entry to the meeting today to reduce the background noise. We will open those lines following the presentation today. If you'd like to speak or if you have a question, please use the raise hand feature. Once your hand is raised, we will acknowledge you and unmute your line. If you hover over your mouse near the bottom of the screen, you'll see the participants tab. That can be expanded if you'd like to see who all is in the call with us this evening. The chat feature is at the bottom of your screen as well. You can maximize that and you'll be able to chat with the chat moderator as well as others in the call if you have any questions or comments. Closed captioning is available during the call. If you want to hit the CC button at the bottom of the screen to enable the closed captioning. If you need to step away, you can stop sharing your camera by clicking on the camera icon at the bottom of your screen. When you return, you can simply click that same icon and your camera will come back on again. Any concerns or complaints can be directed to the State Ombudsman Office at 717-783-8975 or by email at ltc-ombudsman@pa.gov. So without further ado, I would like to introduce Corey.
Good evening. I am introducing Richard Mollot. He is the Executive Director of Long-Term Care Community Coalition. Their website is nursingHome411.org, and their organization is quite impressive. So we're excited to have Richard tonight. Thank you. We'll turn it over to him.
Hi, thanks very much. Thanks, Corey, and thank you. Well, thank you, Corey, for inviting me, and thanks, everyone. So I'm going to share my screen now, and so I have a PowerPoint which I shared earlier, so we can get started. Slideshow, play from start. Okay, hi. So I'm principally going to talk today about some of the resident assessment and care planning issues, but I wanted to also talk about some other resources and information to support family advocacy. As Corey said, our website is nursingHome411.org. Everything that I talk about is all the resources, et cetera. The information is on our website. Everything is free to use and share. You can adapt it for your own family council or organization. We're happy for people to do that. And so there's no real need. Sometimes my presentations can be a little bit, they tend to be very substantive. So, but I always say, don't worry about taking notes or making sure that you get everything down, because everything I talk about, as you'll see, is available on our resources. Very quickly, a little bit about us. The Long-Term Care Community Coalition was formed in 1989, so we just celebrated our 30th anniversary a couple of years ago. We're a nonprofit, nonpartisan organization entirely dedicated to improving care and quality of life for residents in long-term care facilities, specifically in nursing homes and in assisted living. We do both state and national work. Mostly when I started in 2002, we were actually the Nursing Home Community Coalition of New York State, and we only did really New York State work. And since that time, over the past 19 years, we've expanded. We've been doing more national work, but we do our state work is in New York, a little bit in New Jersey. We do provide some technical assistance to organizations around the country. and then national advocacy. We're also home to 2 local long-term care ombudsman programs in New York in the Hudson Valley, which is just north of New York City, if those of you have any familiarity with the New York State map. The focus of our work has always been policy analysis and systems advocacy. So when we started in the 80s, it was really to work on a nursing home law, to have some kind of rules and oversight for nursing home care. And then we have built on that over the years to do work on, improving oversight, improving quality of care, quality of life, and dignity for residents. In addition to that, I would say over the past 10 years in particular, we've done more programs such as this one and produced more materials such as those that I'll discuss today that focus on educating and empowering residents and their families, long-term care ombudsmen, and the people who are working with residents and families. And the reason for that is, as you might know, nursing home problems, unfortunately, are pretty persistent and widespread. And it's so hard to get change, to get the state to do a better job with oversight, to get the federal government to do a better job with oversight. So we've turned over the past 10 years or so to helping to inform residents and their families about what the residents' rights are and how they can best work to overcome the challenges to getting good care and to living with dignity in nursing homes. As I mentioned, I started at LTCCC in 2002, and I've been the executive director since 2005. So today's agenda is I'm going to talk a little bit about the foundations for family and resident counsel rights in the federal rules. Virtually everything that I focus on in my work, and which I'll talk about today, are the federal rules. I mean, the federal rules are really good. They're comprehensive, and they are the basis for resident care and quality of life standards throughout the country. States can have additional rules, but they really supplement the basic federal rules. I'm going to focus a bit on resident assessment and care planning. This happens to be actually when I've done programs for family members over the years, it's often the thing that they are most interested in. And so we've done a lot of work in this area, or provided a lot of resources in this area. And then I'm going to talk about some resources and tools to support resident-centered advocacy by families, by residents, of course, and by those working with them. Before we got started, I wanted to just mention, because this is something that's very much on my mind, and I'm not sure how much others are aware of it, is that during the course of the COVID pandemic, the former presidential administration, to address obviously the vulnerability of residents, for good or for bad, they waived a lot of the requirements for nursing homes, including, as I note here on the left-hand side, staff training requirement, as I'm sure you are all painfully aware, visitation rights of residents. They stopped annual inspections and a lot of complaint investigations by the state agencies, the state departments of health. Most of those waivers have been removed or reduced as of this month. The staff training requirements is still an issue. So for those of you who may not be fully aware of this, is that the CMS, the Centers for Medicare and Medicaid Services, waive the requirements that certified nurse aides have to have certification training of at least 75 hours. I don't recall if PA is one of the states that has a higher training requirement. Many states now, for many years, have had higher than 75 hours of training. What CMS did was saying that states could agree to allow nursing homes to have, to allow CNAs to work, or TNAs as we call it, training, nurse aides in training, as they're calling it, to work in nursing homes without having the CNA certification or having gone through certification training. And they also waived the requirements for feeding assistance from, I think the federal minimum is 8 hours. Again, some states have higher training requirements for feeding assistance to as little as 1 hour. So this is something we've been really concerned about. In short, from our perspective, as someone who does a lot of research in this area, and of course, resident advocacy, If anything, residents needed staff with more capabilities, with more training, with a stronger sense of residents' rights and how to address resident needs rather than less training. So it's a real concern to us right now as to how the country and how nursing homes are going to be moving from this, having these so-called TNAs to back to the requirement of having CNAs. And the nursing home industry is pushing both on the state and the federal levels to have these people grandfathered in. And our concern, I know you've had speakers from the Consumer Voice in the past. We work with them closely in a lot of our advocacy. Both agree that these people should not be grandfathered in, that they should be required over the course of a couple of months to give them some leeway, but they should be required to have all of that vital training of a nurse aide. Importantly, before I move on, I just want to mention the quality of care standards, quality of life standards, cleanliness and grooming standards, toileting assistance, freedom from unnecessary drugs, and pressure ulcers. Those were not waived. Unfortunately, we've seen a tremendous amount of issues here, both in the data and from what we've heard about from families and from ombudsmen across the country, that residents were not getting the quality of life services that they needed. There was no recreation. Residents were really isolated, lonely. Many residents we know died of loneliness or abject neglect. These were not waived. So as I often tell people when I talk about this, and we've been having some visits with people in Congress or their staffers over the past couple of weeks, this is not a warehouse. This is a place where the people who are very vulnerable go, as you all know, more than anybody. They go there because they need 24-hour-a-day care and monitoring. Nursing homes continue to be paid and actually receive billions of dollars in bonus money during COVID-19 to ensure that residents were safe and treated with dignity. But we're very concerned again that there's a tremendous disconnect. And that's why I just want to spend a couple minutes talking about this issue, because it's so important to me. And I think it's unfortunately very under-recognized throughout the past, throughout the COVID pandemic, and now as we're hopefully emerging from it. So as I mentioned, I want to talk a bit about basic rights of resident and family councils, because I think it's important. I'm not sure how familiar you all are with it. Again, and I'll talk about this in a few minutes. We have all this on fact sheets, which you're welcome to use, share, adapt, whatever, however it might be useful. But I just wanted to lay out some of the federal requirements, because I know in my experience and my work, I hear from family members, I hear from long-term care ombudsmen that the nursing home may be putting together the resident or the family council meeting. They may be attending. They may, even if the family council doesn't want them there, they may be taking notes for resident council family meetings, the official notes for those meetings. There's unfortunately a lot of ways in which the facilities, too often, not all of them, but quite often, will try to exert control. And that's why I thought this was important. So the federal nursing home reform law states that nursing homes, quote, must protect and promote the rights of each resident, including a resident's right to organize and participate in resident groups and a family's right to meet in the facility with the family of other residents. And that, of course, goes to family as well as friends, that is recognized. Furthermore, the facility must provide a resident or family group, if one exists, with private space and take reasonable steps with the approval of the group to make residents and family members aware of upcoming meetings in a timely manner. Staff, visitors, or other guests may attend, but only at the respective group's invitation. And lastly here, the facility must provide a designated staff person who is, and I put this in bold, as you can see, approved by the resident or the family group, and who is responsible for providing assistance and responding to written requests that result from group meetings. So again, just I wanted to make sure that you had a strong sense and understanding, if you don't already, of how we approach this and how nursing homes are required to approach this, that this is something that comes from residents or families. I get questions sometimes, must a nursing home have a family group or a resident group. They don't have to have that. And of course, you can find out information about whether a certain nursing home has a family council or a resident council on the Federal Care Compare website. We have that information. We post some of that information about nursing homes for every nursing home in the country on our website as well. But you can find that information. But these things again are generated from the resident or from the facility, or from the family member, excuse me, and the facility has a responsibility to support that, but they are not permitted to interfere or to run it. This I thought was interesting too. I'm going to talk a bit about grievances as well, because the grievance requirements are fairly new, and I think they go hand in hand with the things that we're talking about. The facility, and this is the federal CMS language, the facility must consider the views of a resident or family group and act promptly upon the grievances and recommendations of such group concerning issues about resident care and quality of life in the facility. So as I mentioned a couple of times now, everything we have pretty much is available as a fact sheet. We also have a primer on long-term care standards, on the standards that we've identified. I think there's about 50 of them or so as most important to resident care. The primer is available free as a download or to print out from our website. But you can see here, this is the fact sheet on what the law and what the federal guidance require of nursing homes in regard to resident and family councils. I just want to take you through, if I may, for a minute, because we're going to talk about a number of issues today, and each one of them accompanies one of these fact sheets. Virtually all of our fact sheets are 2 pages, so a front and a back, so they're easy to print out when we're back in nursing homes. I know a lot of, I've heard over the years that a lot of family councils and resident councils use the fact sheets to support their discussion about certain issues and to support their advocacy. So they're easy to print out and to use. Each one of them, and I hope that you can see the purple here on the lower left-hand side, that includes a description of what the requirement is. So this on the left-hand side is resident and family councils. And for each of the fact sheets, we include the CFR and the FTEC. So the CFR, that's the Code of Federal Regulations. And by the way, we always note this on the top of the fact sheet, and you can see in some of the language up here. But the CFR is the Code of Federal Regulations, federal rules, where this particular right or responsibility comes from. And the reason why we do that, as I say, now I pilot tested actually a lot of our fact sheets with 2 family councils over a 1.5-year period. And what I used to say to them, and I'll say to you, is that it's not just that, these issues, these concerns, these rights are not just that some bald guy came into to a meeting one day and said, oh, these are your rights and this is what you should have, is that the rights are founded in explicit language in the federal rules. And that means that you can use them with confidence going forward. You can use this language. Everything in italics here, if you can see it, is, if you can catch the italics, comes directly from either the law, the Code of Federal Regulations, or the federal guidance for nursing homes and surveyors. So that is to give you, just to make sure that you understand this is not my idea, or these are not my ideas of what should be, my pie in the sky ideas, my hopes, my dreams. This is what nursing homes are required to provide and what residents have a right to accept. And of course, as family members, and I've been a family member a number of times myself, but we have a right to accept for our residents. The last part, very quickly, is we also include the FTEG, and I can't see everyone, so I won't ask. Usually I'll ask, if who knows what an FTEG is, but in short, for every single resident right or quality of care requirement, when that is cited by the state inspector, the surveyor, or a federal surveyor, it has an associated FTEG. So here, the rights regarding family and resident council has an associated FTEG. So if your facility was cited as violating one component or any component of this standard, it would be cited as F565. Why do I include this here? Why is that important? Because every single nursing home has to have available for public view, usually it's at the front desk or it could be attached to a bulletin board, a copy of their latest inspection, which is called the Statement of Deficiencies, Form 2567. So they have to have that inspection report. And when you look at that inspection report for your nursing home, you can see it will always say on that report any of the violations, and for each violation of a standard of care, we'll have an F tag. So what we are doing here is we're kind of helping, I hope, for you to connect the dots. So if you see, say it's F565, this resident or family council, you can say, oh, well, I could go back to our materials. You can see what it was that the facility violated, and you could see what the expectation is for the facility, what they are supposed to be doing to come back into compliance. And this can help inform your advocacy. It could help inform what you do, what your expectations of the facility staff, of the facility administration going forward, because it helps you to understand what it is that the facility should be doing. It also helps, I think, families and residents understand the past problems and the recent problems that facilities have had. So if you go to, as I said, any facility, every facility is required to have this posted for public or available for public view. In addition to that, every state has to provide the statements of deficiencies on their website with nursing home information. That's a federal requirement. So Pennsylvania, the website for Pennsylvania, the section in which they provide information on nursing homes has to include that for every single nursing home. And then lastly, Care Compare, which is the federal website for nursing homes and other types of providers, hospitals, doctors, et cetera. If you go to Care Compare in the nursing home section and you look up your nursing home, I'll show you that later on, you can see the most recent surveys, both complaint surveys, if there are any, and the annual survey. And you can see what the F-tag was and an explanation of what the violation was that the facility that was found for the facility. So we have that information. And then in the boxes that we include on many of these fact sheets, you can see this, we just provide information for you. On the left-hand side, some information, what is a resident or family council? On the right-hand side, some considerations for resident-centered advocacy in regard to the issue here, resident and family councils. At the bottom here, we had some room, so we included links to more resources, including our website and the Consumer Voices website. So I hope that that is useful for you all. I'm going to talk about next assessment and care planning. So, and this was, as I mentioned, when I was doing the pilot testing for, we have a dementia care advocacy toolkit that we developed with funding from a foundation about 8 years ago. And I pilot tested that. I went to monthly meetings for 2 family councils where we were located in New York City. So they were located in New York City as well. And every single month I would do a presentation for them about a specific resident right. And out of that, we developed these fact sheets. So resident assessment and care planning was by far the one that was most popular. So it's really interesting. And I understand why you would want me to talk about that today. So I try not to read from these slides, but I'm going to do that here just to give you some information. Again, everything in italics comes directly from the federal rules or from the federal guidance. So here it says the facility must, not the facility can, not the facility may if it feels like it or if it has enough staff. The facility must conduct initially and periodically a comprehensive, accurate, standardized, reproducible assessment of each resident's functional capacity. A facility must make a comprehensive assessment of a resident's needs, his or her strengths, their goals, their life history, and preferences as individuals using the resident assessment instrument specified by CMS. And lastly, and this was, I think, so important, is that the assessment must include at least the following. Again, this is the federal rules, not my opinion or not my wishes. This is the federal rules. Must include identification, demographic information, information about the residents' customary routines, their cognitive patterns, how they communicate, their vision and mood and behavioral patterns, their psychosocial well-being, of course, physical functioning and any structural issues they may have, maybe balance, etc., continence, any disease diagnosis and health conditions, their dental and nutritional status, skin condition. As I'm sure you know, pressure ulcers are a very serious issue in our nursing homes. Their activity pursuits, what they like to do. Not everyone wants to play bingo, and that shouldn't be the only activity, or sitting in front of that TV set shouldn't be the only activities that a nursing home provides. Of course, medications, any special treatments that they need, and then discharge planning. This is something that's actually, I think, if I remember correctly, fairly new, but there are requirements now about asking a resident or his or her loved one about their whether they want to leave the facility. So a host, as you can see, a whole list of things. I've been to resident assessment and to care planning meetings. It's really hard. Too often, in my experience and to my knowledge, they tend to be very quick. They don't ask a lot of questions. They tend to be very top-down, meaning that whoever is running the meeting, the staff is directing what is being discussed and not necessarily open to the input of the resident, his or her family, etc. So this is a really important information to have to use. As we note, and you'll see we have of course, a fact sheet on this, as we do on many things. The fact sheet says you can use this as a list to help you prepare. So when your resident needs an assessment, or because his or her status has changed, something has changed, and that would and should trigger a new assessment, or it's time for his or her semi-annual assessment. This can help you prepare for that assessment by thinking about, okay, what are the things that I want to make sure are discussed? What are the things I want to make sure are addressed in the resident assessment? And then care planning. And as you can see here, I have boxing gloves, because to me, when in the year and a half that I was working closely with those family members, it kind of occurred to me that it's kind of like a 1-2 punch. You have the resident assessment, which, as you saw, has to be really comprehensive, not just clinical, but also what are their goals? What are their abilities? What is their background? And then the care planning here, as CMS notes, again, this is CMS's language, the facility must develop and implement, both develop, not just develop and file in a drawer, develop and implement a comprehensive person-centered care plan for each resident, consistent with resident rights, that includes measurable objectives and timeframes to meet the residents' medical, nursing, mental, and psychosocial needs that have been identified in the comprehensive assessment. So you have the assessment, you have the care plan, and together, those should be the basis for really good care. Because just to go back, I mean, look, everything that's here. We're talking about the person's cognitive abilities, their clinical needs, their goals and their desires, their background. Who have they been? Who are they now? Where are they going? And identifying what those needs are, what those goals are, and then basing the comprehensive, again, not my words, CMS's word, comprehensive individual-centered care plan based upon the resident. And also, I'll say it again, includes measurable objectives and timeframes. To me, it's just so critical and so easy for those things to get lost in the shuffle of a 15 or 20-minute care plan. I hear still from family members, and this has been for years, that they were told that the care plan meeting was happening at 3 o'clock in the afternoon the following day, and they work and they can't attend, or they can only come in by phone. Who's going to be there? Who's going to be speaking for the resident? No. They have to, the facility doesn't have to have a care plan meeting at 3 in the morning because you work you and your family members work the day and the evening shift, but they do have to tailor this and be responsive to the resident and the resident's representatives. So I'll just quickly talk a little bit more here. So the comprehensive care plan has to describe the following: the services that are going to be provided to help the resident attain or maintain his or her highest practicable physical, mental, and psychosocial well-being, and any services that would otherwise be required under this whole plan and the assessment, et cetera, that would otherwise be required to happen, but are not being provided to the resident due to the resident's exercise of rights, including the right to refuse treatment. So important here. So there may be things that the facility, thinks, that the resident wants to do, perhaps, or the resident can do. Now, I'll give an example. My Aunt Hilda was in a nursing home for many years, and my aunt and my mother used to laugh because she would be out, we'd come to visit her, and she'd be out doing occupational therapy. She was in her late 90s. She lived in the facility till I think she was 103 when she passed away. And they would be helping her walk up and down the hall, and they thought it was funny. Oh, occupational therapy, what kind of job is Hilda going to get that she needs occupational therapy for? But the point is that Hilda was able to ambulate. She was able to walk. She needed some help, but it was the facility's responsibility to make sure that she did not lose her ability to walk and become bedridden. So that was the facility's responsibility. Now, it could be some people say, I don't feel like doing that. Maybe the care plan is that you're going to have occupational therapy 3 times a week. But as I sit here in this last bullet we were talking about, maybe the resident says, no, I don't want to have that. I just don't feel like it. I don't want to have occupational therapy, or maybe I want to have it once a week. But they have to document that. That has to be documented. And why is that so important? Because too often facilities might say, oh, she didn't want to do that. Oh, they'll make an excuse for not providing a service, especially therapy services, when the resident was not really asked about it, and the facility might write in, oh, they turned down services when in fact those services were not provided. So here we're all in the room in terms of the care planning process, and we're all figuring out, this is what we're doing for Hilda or for Jimmy or whomever. This is what, again, based upon that resident assessment, this is how we're addressing everything in the resident assessment and what we're going to do, measurable objectives and timeframes. The care plan also, as I note here in the last orange bullet, in consultation with residents and the residents' representatives, it describes the resident's goals for admission, his or her desired outcomes, whether he or she is long-term care or short-term care, doesn't matter. The resident's preference and potential for future discharge, as I mentioned before, that's something that CMS is, the federal agency is wanting to make sure that people are asked that question. Discharge plans in the comprehensive care plan as appropriate. A comprehensive care plan must be developed within 7 days after completion of the comprehensive assessment. So again, not letting the facility just sit on, file away these things. These have to be done appropriately. By these, I mean the assessment and the care planning, and they have to be done in a meaningful way that, again, as CMS itself demands, and as we have a right to, has to be done thoughtfully and in a way that is focused on the resident as an individual. Oh, and by the way, so there's some questions, I think, or comments that came in, and I'll leave time. I'll be happy to stay for as long as you want me to provide any questions, to answer any questions or respond to any comments. So here is the fact sheet. Again, it's a 2-pager. As I mentioned a couple of times, these are really popular and important issues for the families that we've worked with over the years. So we have other materials as well, including, and I'll talk about some of the resources that we have on our website, but we've developed forms for people to use. So really we've kind of translated this into a form that you can fill out and take with you to meetings, or even to keep track of, again, as I mentioned earlier, it's hard. I mean, there's a lot of pressure when you're in a resident assessment or in a care planning meeting, and it's hard to remember. I mean, I'm in my 50s, and when I go to a doctor, my dermatologist or my dentist or my general practitioner for an annual checkup, I don't remember everything that I may want to talk about or that I may be concerned about. So sometimes I try to remember to write it down. What we've done is try to give you some of these resources and forms so you can think about it ahead of time and be as informed and as able as possible to participate in an effective way for your resident. So I'm going to move on. I want to talk, as I mentioned before, a little bit more about the complaints and grievances, because this is a big issue that we hear about from families. And this is something that's fairly new in the rules, in particular regarding a grievance officer. So this is the basic standard. And I don't think I mentioned it before, but the rules have been out since 1991. So in 1987, all the law that I talk about, the nursing home reform law came out in 1987. The rules, the regulations to implement that law came out in 1991. And they were in existence for 25 years. And then in 2016, CMS, the federal agency, revised those rules. They did not make any changes to the rights of residents. The revisions really provided some updates, and they made some smaller changes to better effectuate the residents' rights and the care standards. So those care standards and rights didn't change, but there were some tweaks that were made to address some long-standing issues. For instance, very quickly, we talked about infection control. And as you all know, when COVID-19, infection control and prevention was a devastating problem for nursing home residents, and of course for us as family members and advocates over the past year and a half. In 2016, one of the changes that CMS made was to require that facilities have a part-time infection preventionist in the building, every week or however. It had to be on a part-time basis. And understanding that the long-standing requirements that facilities have an effective infection control protocols and practices and policies, that was too often ignored. So we're not talking about, I don't want to divert our attention too much, but that was one of the changes that they made. Another change that they made, which I want to talk about now, is that they required nursing homes to have a grievance officer. And as I'm sure you know, and I know this personally as well, is that if you have an issue, if your resident has an issue in the nursing home, quite often the first thing that you'll do is you'll talk to the aide or you'll talk to the nurse who comes in to provide care for the resident while you're visiting. You may call the facility and speak to facility staff to say a complaint or a concern that you have. Could be about food. It could be about maybe your resident has a bruise. Maybe your resident is not getting therapy, or a complaint about the medication, et cetera. Or you'll go to the nursing desk, or you might speak to the administrator. These are things that we do as family members. And what we know is that over the years, from experience, that quite often those issues may be addressed, or the person will say, oh, we'll take care of it. And either it doesn't happen or it's taken care of, but only on that shift, and it's not integrated. It's not addressed in a way that is meaningful for the resident. So the rules in 2016 require that every facility have a grievance officer. So I want to spend some time and talk about how that is being and can be implemented to support your advocacy on an individual level for your resident. So just very quickly, these again are the rules since 1991. For 30 years, the resident has the right to voice grievances to the facility or other agency or entity that hears grievances without discrimination or fear of reprisal. The grievances, including those with respect to care and treatment which has been furnished, as well as that which has not been furnished, because as you know, neglect is a big issue. The behavior of staff and other residents and other concerns regarding their facility. The resident has the right to, and the facility must make prompt efforts to resolve grievances. So often, I mean, up to and including today, I've heard about, facilities that just don't respond to residents, don't respond to families, even to organized family councils. The facility must establish a grievance policy, to ensure the prompt resolution of all grievances regarding the resident's rights. Upon request, the provider must give a copy of the grievance policy to the resident. Of course, as family members, you take, with the resident's permission, or if the resident lacks capacity, you take the resident's place in all of the resident's rights and speaking for the resident. So here are the requirements for a nursing home grievance officer. So as I mentioned before, quite often people, and still do, they would complain. It makes sense. You complain to the people on the floor, maybe to the administration, et cetera. Now, what CMS recognizes, that was not always effective. And quite often it was ineffective. So every nursing home has to have a grievance officer, and it is his or her responsibility to oversee the grievance process, receiving grievances and tracking grievances from the start to their conclusion. They're responsible for leading any investigation by the facility. They're responsible for contacting the medical director, if that's the person, or the pharmacist, or the administration, or the director of nursing. They are responsible for doing that legwork, not you. They're responsible for maintaining confidentiality of all information associated with the grievance. In particular, if the person who made the grievance wanted to be anonymous, it's their responsibility to keep it anonymous. Even though they work for the facility, this is the role that they are required to have under the federal rules. They are required, and this to me was so important. I was so excited. So we did a lot of work with CMS on these rules. They are required to issue written grievance decisions to the resident or the person making the complaint. So important, because how often have we been told something will be taken care of, and then it's not? Here you have a written grievance decision that you can take, keep, and use in the future if necessary. So here is our fact sheet on resident grievances. It talks about the right to voice grievances, the requirements that a nursing home's grievance policy has to have. As I mentioned before, you can ask for the grievance policy. This includes what the requirements for a grievance policy. So if you don't see these things, you can ask about them. They are they're required to be in there. And then the requirements for the grievance officer. And I just wanted to include also, the agencies for filing a complaint. So we have on our website, you can link to, we link to all the ombudsman programs around the country. You can also, and I highly encourage this, you can contact your state and your federal legislators. So the openstates.org here under the second phone, that will get you a link to information about your state legislators, and the congress.gov /contact us is for congressional representatives. I think, too often, what I hear is that the facility is just not responsive. And the state agency, the State Department of Health, does not respond to complaints very well, or is not overseeing care in the facility. And I tell people, call your state and your federal legislator, because that can make a difference. We also have contact information for every state's governor's office here, usa.gov. As I mentioned before, I believe the state Medicaid fraud control units, every state now has a Medicaid fraud control unit. I think almost all of them, except for one or two, are housed in the state attorney general's office. Every state Medicaid fraud control unit has a patient abuse hotline that you can contact. The CMS regional office, we put those contacts up here at the bottom, the last phone on our website. And of course, all this information, this page is available on our website as well, with all the links to this information, so you don't have to write it down. But the regional offices are responsible for overseeing the state agency. So if your Department of Health is not responding to your complaint, if they don't substantiate a complaint, and you think they're wrong, or they come and they do an inspection, and I hear this all the time, oh, the facility had no violations, and you know that all the things we've been talking about today are not happening for the residents, you can actually complain to the regional office, which is overseeing your state. These are ways in which my advocacy and our work, but also we want to encourage others to make their voices heard, because too often the states just don't do a good job overseeing nursing home care, overseeing safety, overseeing residents' rights and dignity, and we need to up our voices. We as a whole, I'm not talking to any of you specifically, everyone should do what they feel comfortable with, of course. And then lastly, on the left-hand side, as I note, for quality of care cases only, you can contact the U.S. Attorney General's office. Every state, I believe, has a U.S. AG's office, and ask for the Elder Justice Coordinator or the Healthcare Coordinator. And that's another way to voice your complaints. And it's a way in which we can be heard by speaking out to our legislators and getting them to put some pressure on the nursing homes. What I hear, by the way, over and over again from legislators is that they mostly hear from nursing homes and from the nursing home lobby associations, because nursing homes make a lot of money. They pay a lot of money to lobbyists, whether it's Harrisburg or Washington, D.C. And so that's who they hear from. So, people may know that nursing homes are not great places to live generally, but a lot of legislators think, oh, not in my district. In my district, they're not getting enough money, because that's what they're hearing from the lobbyists. So it's really important that they hear from us. So lastly, I'm just going to talk about some of the online resources that are available. I've mentioned a couple of times Care Compare. That's the federal website for which you can find information on pretty much any type of care provider. Anyone that is taking Medicare or Medicaid funds would be listed here. So there are separate sections for nursing home care, for hospital care, for hospice care, for home health, and I believe for doctors. And you could do a search on their website for information. This is what it looks like. So you can type in your location, your zip code, city, or state. You can select from one of the provider types, as I mentioned, nursing homes, doctors, hospitals, and then you could type in a keyword. So if you wanted to look for a specific nursing home, you could try putting that in there and then do a search. This is just an example. This is a nursing home actually by where I live in New Jersey. And this just shows you the front page of how it looks. I haven't looked at the Pennsylvania state website. As I mentioned before, the states are also required to have a nursing home website, a site where every nursing home is listed, where you can find the deficiencies, the violation statements, and other information about nursing homes. Frankly, they tend, in my experience, not to be that great. So I usually use the federal website. But here you can see what it provides. It provides overall rating, and then that rating is based upon 3 components: the health inspections, the staffing, and the so-called quality of resident care. So that is what makes up the overall rating. This facility, the Waterview, has this red sign, meaning that it's been cited for abuse. That's the abuse icon. So there's some other information. And then you can dig deeper to find, if you look under the health inspections, you can find that information about, and you could find out the actual language of their previous statements of deficiencies, complaints, outcomes of complaint surveys, etc. So that's what's provided on the federal website. It's not perfect by any means, but it's by far the best resource out there. I don't personally go to or trust places like A Place for Mom or caring.com, because they get paid by the nursing homes to be listed. So they're different. They're not, they use some information from Care Compare, but again, they're paid by the nursing homes for the listing. And I feel the same way about like USA Today, and sometimes local newspapers will have like the best nursing homes in the state. I've always refused to participate in those. And I think they are not a good idea at all. Really the best place to get just overall information, again, not perfect, but is that Care Compare website. And then lastly, as I've been talking about, we have a lot of resources on our website that I wanted to alert you to and share with you. One is I highly encourage you to keep up with us. We have a lot of information that we provide on our podcast. We have a Facebook page. We have a Twitter feed. You could sign up for email alerts. You can see by going nursinghomefour11.org/social. We have a YouTube page. So we have webinars on a lot of the, dedicated to a lot of the standards that we talked about today and much more that are, generally about an hour long. They're available on YouTube and on our website as well. And we have a really interesting podcast that our communications director does with a variety of people. It could be researchers, it could be people who work in advocacy. We have done it with long-term care ombudsmen, et cetera. So there's some interesting programs that we have podcasts. If you have 25 minutes or a half hour, I've listened to them while I'm making dinner sometimes, and I find them very informative. We have an state information page. So we have a map, which is interactive. So you can just click on Pennsylvania, or you can go to nursinghomefour11.org/states/PA, and that'll take you to the Pennsylvania page. But we have state-specific information for every licensed nursing home in the country on their staffing, on their quality ratings, ombudsman resources, and more. I'll take you very quickly to the Pennsylvania page. So this is what it looks like today. On the right-hand side, you can see we always have, and these are updated as frequently as possible. The data, nursing homes don't have, they don't change every day. Every quarter, actually, is how often the staffing data are updated. So as soon as the federal government uploads the latest staffing data, we download that and we put it in user-friendly state files. I'll show you one where you can look up your facility's staffing or the staffing levels of facilities in your county or in your town. We also have the first purple button is information on nursing homes, including their ratings. We also have separate information on 1-star and special focus facilities. Those are the most poorly performing facilities in every state. We have a link to the state long-term care ombudsman websites. For Pennsylvania, we include a link to CARI, the Center for, oh my goodness, I forgot what CARI stands for. I've known them for years, but it's a really good organization in Philadelphia that does a lot of resident advocacy. And then on the left-hand side, we include any news or reports that we have related to the specific state. So here it says, as you can see, in our winter 2021 quarterly journal and in our fall 2020 journal, we had articles that related to Pennsylvania. So we included them here. And you'll see this for every state, more or less. And we are constantly building, by the way, on these resources. So as I said, they're updated whenever appropriate. We update the ratings, I think bi-yearly or so. And then the staffing data is updated on a quarterly basis when the new data are published on a quarterly basis on the federal website. So just very quickly, I just wanted to show you a chart. I know it looks a little bit messy here, but if you go to our website, this is for the fourth quarter. It's the most recent quarter of the fourth quarter 2020, excuse me. And you can see the provider name is the second column, the city, the county in which it is in, and then we provide information for every single nursing home on the RN hours, the LPN hours, and the CNA hours in each facility for the average day. So what the federal government does, and this has only been since 2016, 2017, is that they require nursing homes to report all of their staffing for every single day, as I said, on a quarterly basis. So at the end of the quarter, the facilities report for 90 days, every single day, how many RN hours, how many LPN hours, how many CNA hours. They have to say how much contract staff that they're using as opposed to their own facility employees. because contracts, using too much contract staff is always kind of a red flag for us. And then they also have to report certain non-nursing staff, such as the activity staff, social work staff, the medical director staff time, et cetera. So they publish that every day for every day of the quarter. So again, a 90-day file for every single nursing home in the country. So what we do is we download that file, and it's well over 1 million lines of data, 15,000 nursing homes with every single day for every single nursing home reported out. And we average it out for every nursing home for the quarter. And that's what you see here. And then in addition to that, if you download the data sheet, you'll see that we have the total staff time, but then we have the average staff time per resident per day, because that's how we generally talk about it, is that federal studies have shown that the typical nursing home resident needs to have at least 4.1 hours of nursing staff time per resident per day. So you can see what your facility or facilities in your community are providing. You can actually filter it, as we know here in number 3, up or down. So you can filter from the highest level of RN hours per resident per day, registered nurse hours to the lowest. And therefore you can really see what's going on, how your facility compares to others in the area, and whether they're meeting that threshold. As I said, 75% of facilities don't, but on the other hand, 25% of facilities do, meaning this is not something that can be done. It can be done, but we need to make sure that it's enforced so that everybody is doing it. So that's what the staffing data look like. I just broke it down here. This is actually a county that, one of the counties in our Amazon program. And so we provide this, you could look at it just to make it easier, rather than having all the facilities in your state, you can just pull out, this is Westchester County, which is north of New York City. You can just pull that out into a separate file, or even just pull out one facility. This is what our data center looks like. So we have, as I just discussed, the staffing data, we have the nursing home ratings and information. So you saw on the Pennsylvania page, you can access a lot of it there, but you can also access it through our data center. In addition, we have information on antipsychotic drugging rates, other things that we publish on occasion. Unfortunately, we used to get that antipsychotic drugging data on a quarterly basis, and now we're having trouble getting it. The federal agency has not been responsive for over a year, and that's why we don't include it on the state pages any longer, but it is available here. I just wanted to show you one of the podcasts that one of our recent podcasts was A Jail Within a Jail. It was talking about the Resin experience in a New York City nursing home during the COVID-19 pandemic. But we have interviewed data experts, academics, nursing home residents, staff, ombudsman, as I mentioned before. So we really encourage you to listen, to subscribe. We would appreciate if you reviewed us on Spotify or on Apple Podcasts. We have free monthly programs. Our last program, these are monthly webinars that we do. They're almost always, I think they're always on the 3rd Tuesday of the month at 1 p.m. Eastern. They're always free. Our last one was on Comfort Matters. It was on dementia care and reducing the reliance on antipsychotics. We had Tina Alonzo, who's pictured here. She's from the Beatitudes Nursing Home in Arizona. She is just honestly a rock star when it comes to dementia care, resident-centered dementia care, understanding residents with dementia, and providing them with good care, not care that is just, not just sedation, but really providing good resident-centered care. Our next program is next week. It's on involuntary nursing home discharges. That is from someone who's recently did a study on nursing home discharges to homeless shelters in New York. And they'll be talking about that. This is a national issue. She's focused on New York, but nursing home discharges, inappropriate discharges, is a huge complaint nationwide. And then last, some of our resources for advocacy that I mentioned before. This is our learning center. You can register for news and updates. You can, as I think I mentioned, we provide a free Zoom room for family councils. It's private so that they can meet. This is the button on the second button is to request a meeting to have the Zoom room for your resident or family council. We have links to our fact sheets, to our handouts, to the webinars I just mentioned, forms and tools for resident-centered advocacy, the Dementia Care Advocacy Toolkit that I've mentioned a couple of times, and we have a Family and Ombudsman Resource Center. This is just a snapshot of that, where again, you can see, you can sign up there for the Zoom room meetings. You can see some of the fact sheets, etc. That picture is my mom on the right-hand side with my Aunt Hilda, who I mentioned before, who since has passed away, who is in a nursing home. These are some of our forms and tools for resident-centered advocacy. So we have it as a Word file on the left-hand side and as a PDF file on the right-hand side. So whatever is easiest for you to use, to print out, or to use on your phone or on your computer or your mobile device, you can use it. But we have family council meeting notices, resident assessment worksheets. Remember I mentioned before about the resident assessment. We have a whole worksheet for that. This is what the family council meeting notice looks like with the meeting agenda. We just put a sample agenda that people can use as a template for their meetings, and it continues. I just made a picture, took a snapshot of the front page here. And then record keeping form for resident concerns. Again, kind of getting back to what I was speaking about with grievances. I heard from a lot of family members, especially, since once we started doing that project 8 years ago, that, they would come up to me after a meeting and they'd say, I've had this problem with my mom for 3 years, or I've been complaining about that since March, that, XY issue since March. And I would always think, and I would try to say to them politely, those are certainly valid concerns. But the problem occurs is that if there is not a set date that you made the complaint, who you spoke to, what they said they were going to do, it makes it very hard to act upon. So we want to put together a simple record-keeping form for families and for residents to use when they have a complaint, that they could, one, just very briefly put in the issue, who was involved. Was it a certain staff person? Who they spoke to about the issue, what the response was, and what actions were taken. And then this fact sheet can actually, this record-keeping form continues, so you can continue to keep track of it and keep track of the dates. So instead of saying, I've been complaining about this for 6 months, again, that is valid, I get it, but it's much more actionable when you could say, on March 15th, I talked to the RN Higgins at the front desk about my family member and issues with her medication. And those issues are still taking place 4 weeks later. What are we going to do about it? And then lastly, I think this is last, we also put together a piece on resident preferences. And this is especially useful for people with dementia who may not be able to say, what their preferences are. As that too often, as we talked about before, the facility, the tendency of facilities is to provide care, kind of like a factory. Where everyone gets, it's time for medication, it's time for medication rounds, it's time to wake up, it's time to get ready for breakfast, it's time to come back from breakfast, etc. And that's not what the standards require. As we were talking about in the care planning, the resident, the care and the approach to residents is supposed to be resident-centered, based upon their schedule, their needs, their goals, their desires. So here we put together just a sheet that you can use to any extent that you like, or share with staff, what the preferences are, when the resident likes to be waking up, what they prefer to be called. Not everyone wants to be called honey or sweetie pie. Some people, especially older adults I know, find it very, very demeaning and offensive. They're not, a 20-year-old sweetie, they have a name. My aunt liked to be called, by her name, Hilda. These are things, you could write down things that the resident enjoys, that they find comforting, things that about them, so that their care staff knows a little bit about them. And that was the last slide. I know I spoke a lot, so I'm sorry I took up a lot of your time, but I'm going to stop sharing now, and I will stay on or not for as long as you like.
Richard, we have a few questions in the chat in regards to personal care homes. And just so everyone knows, personal care homes are licensed state to state. So Pennsylvania has our own personal care home regulations, but I think we will review our version of personal care home care plans. They're called resident assessment and support plans, perhaps at our next personal care home resident rights presentation. So we'll make sure that all the personal care home loved ones get that information. So we'll touch on that in the future. But there were also some questions about discrepancy between the regulations and what the homes are actually providing. If you have some insight on how that can be better facilitated.
Sure. Well, that's why we're here. There wouldn't be a need for family councils. There wouldn't be a need for a long-term care ombudsman if the facilities were doing what they were required to do. And that's why I should say a lot of what I talked about today, the grievance officer, the right of the family, the right of the resident, the additional rights of the family council and the resident council to voice grievances both in and out of the facility, to use the resources that we have. As I mentioned, we had a lot of fact sheets, et cetera, on residents' rights that can be really useful to understanding what your residents' rights are in regard to any specific issue, and to help you advocate for that to happen in the life of your resident, both within the facility and outside of the facility. So I remember when I was, as I mentioned a couple of times, I pilot tested these fact sheets with family councils for 18 months, two different family councils for 18 months. Every single month I attended their meetings. And I remember talking about some of these issues. And I remember one meeting, the family members were visibly angry with me as I was talking. And I couldn't understand why. And it's for this very reason, because what I was talking about, the rights that I was talking about, were so different from the reality that their residents were facing. And that's, as I said, I've been a family member. I know it's hard to advocate, it's hard to keep track. It's a lot of work. It's taxing emotionally. But I think of course, we all do what we can do, but hopefully having knowledge, and that's what I said to them then is, it's hard, it's challenging to get good care and humane care in a nursing home. But if you don't know what the residents' rights are, you can be guaranteed that you'll never get that. So one, having a knowledge of what our rights are, and then working, I always, my personal view is to start from the bottom up. So start with the people on the floor. I know residents who have told us that they use these fact sheets in resident council meetings, families are using family council meetings as well. And they'll say to the staff person, they'll bring it to the staff person and say, look, these are my rights. How can you help me achieve them? Because sometimes people on the floor are not fully informed about those rights as well. And then I say, like I showed you that page that we have on our website with different places that you can make a complaint. I think, unfortunately, the reason why we have this discrepancy between the good standards and the unfortunately not very good care and quality of life that many residents have, I would say the vast majority of residents have, is because we don't have good state oversight. That's the central part. I've pretty much dedicated my professional life to trying to improve state oversight. And as you can see, some of the language that we talked about is really good. It's a matter of getting the states to be doing that. And how do we do that? We inform family members, we inform the staff. And if that doesn't work, if that doesn't result in change for our residents, we talk to the grievance officer. We file a complaint with the ombudsman office. We file a complaint with the Medicaid fraud control unit, or with the state health department. And if you don't get the results, of course, this all depends. It could be, if it's something minor, then you could take longer. If it's something that's more acute, then you could even call law enforcement. If it's something that you're worried about the residents' safety or well-being. And speaking to legislators, I think is really important. It's a way of getting movement, alerting legislators, alerting both on the state, on the state and the federal level, calling those offices. They're there to help you, and they need to know that there are issues going on in the facilities in their communities. Otherwise, all they hear from are the nursing home industry lobbyists who are not telling them about the bad things. They're only telling them about what the nursing homes need, not what your residents need. So it's challenging. And as I said, and I showed you, I've been a family member myself, and it can be really hard and really heartbreaking at times. But I think, we know, I should say, not I think, but I know that having a empowered family council in a nursing home, studies have shown make a difference for everyone in a nursing home, both the residents who have family members on the family council, as well as residents who don't. So it's hard to see change sometimes, especially in nursing homes, but we really do make a difference, and your voice is really, really important. So I hope that's helpful. I know it's not perfect by any means.
Richard, you were talking about speaking with your legislators, and I know you had recommended or said that the general view is to have 4.1 nursing hours per day per resident. Pennsylvania currently has 2.7 as our minimum standard. And there was just a question as to where does the 4.1 come from? Is that a federal recommendation? Who's that come from?
Sure.
Advocacy?
So no. So that's actually a federal recommendation. And that comes from, there was a study that that CMS, the federal agency, ordered about 22 years ago now, 21 years ago, came out in 2001, and it's called the Appropriateness of Minimum Nursing Home Standards. And what that study found was that in order to meet just the clinical needs of a typical nursing home resident, so that doesn't include the right to care with dignity, it doesn't include the right to psychosocial well-being, all the things we talked about in the assessment and care planning, just talking about the clinical care, meaning basic clinical care needs, facility needs to have at least 4.1 hours of care staff time, and 0.75, 3/4 of an hour of that time should be provided by an RN, a registered nurse. And study after study has shown since 2001 that the role of the RN, even though he or she is not providing a lot of bedside care, that's mostly the nurse aides, but the role of the RN is crucial in overseeing resident care and safety and the provision of care and services on the floor. So both of those go hand in hand. And so and that's again the data that you can see for your facility. So that's where it comes from. They found that below 4.1 hours, a resident was likely to deteriorate in their clinical well-being or functioning, not because of the natural progression of aging, but because of the lack of services and supports.
So do you have any recommendations as far as the staffing crisis that we're faced with? I mean, it is national, but in Pennsylvania, we are really suffering with just not enough staff, either willing or able to provide that care to our residents.
Right. Well, and this is, as I've mentioned or alluded to a couple of times, the industry is extremely powerful, and they have kind of framed this whole issue for the public, including for our legislators, as, oh, we can't hire enough staff. This is a totally self-fulfilling and self-generating problem, is that facilities, two things. One, the pay is very low for nursing home care staff. Two, the working conditions are terrible. And I'm trying to think, it's the CDC, there's actually a data website that the US government has. And year after year, it shows that the most dangerous or the second most dangerous profession in the country is providing nursing home care. And a lot of that is due to short staffing, is that, you know, the resident will need an assist from 2 staff people, and there's only 1 staff person around. So that staff person will help the resident will come on balance, she'll fall, the staff person will fall and be injured. So it's very dangerous. And then the other issue that we have studied over the years, and that others have studied as well, is that the working conditions are terrible. So low pay, terrible working conditions, and and it's a very dangerous job. So nursing homes, unfortunately, they've set up a business model, I should say, that profits off of this by always having a lot of staff turnover. And some nursing homes have 100%, 200% turnover. So it's not an issue of there's no one out there. It's the issue of that you've chewed up and spat out the people who are able and willing to work for you. And I was actually on a call a couple of weeks ago for the industry talking about this issue. And the person who was leading the call said, we have to admit, we have a very big back door, meaning people are coming in, but they're exiting just as fast. And that's because a part of it is because nursing homes don't have enough staff. So it's really, really hard to work in a nursing home. And people, you know, they might go to a nursing home to work there because they want to provide care and services. And they find that they are working in an environment that is very demeaning and very dangerous for very low pay. So when the pay goes up at McDonald's or at Walmart or wherever, they go there because they don't have to be treated like garbage to make $13 an hour. But let me just say, the most important thing here, and this is everything that we talked about again, getting back to the care, resident assessment and the care planning, the facility, when they take in a resident and when they retain a resident, they are making a promise that they have the staffing and the supplies that they need to provide safe and humane care and to meet all of the needs that have been identified in the assessment and that are in the care plan, period. And to me, there is nothing more disgraceful and outrageous than the fact that we allow nursing homes to take in as many residents as they want to without having sufficient staff. If they don't have enough staff, they should stop taking in residents. That to me is the fundamental requirement. I've worked in my organization for close to 20 years now. If I made promises, if I took money from foundations to provide services, to do a study, or to provide this website, and I just said, well, you know what? I don't have enough people to do it. Sorry, I would be fired. But we allow nursing homes to treat their facilities as if they are warehouses. And that is it's just hard for me to imagine. I know I'm an advocate, but it's hard for me to imagine anything that is more reprehensible than nursing homes being permitted to just take in residents without having enough staff. If you don't have the staff, you are not supposed to be taking in more residents. And that seems to me to be the most fundamental of the requirements. You don't have the staff, you don't take in the residents.
Richard, would you mind if we share your PowerPoint to our participants here?
Oh, not at all. That's fine.
Okay, great. And I see Jeannie Urban has her hand up. You want to go ahead, Jeannie?
Can you hear me now?
Yes.
Okay. Thank you, Corey. Thank you, Richard. My question is, Richard, how do you feel about the state legislatures that have forgiven nursing homes for what happened during the COVID crisis? The excuse of their liability, I guess.
We were completely against that from the very start. I think it's inexcusable. And it's just another frankly, it's another example of how powerful the industry is, and how too often our state legislators and our governors listen to the industry as if they're their constituents, rather than us as citizens, as voters, as families. That to me is, because that should never take place again. And I'm from New York, and as I'm sure you've heard, our Governor Cuomo here got a lot of heat for this. But nursing homes, again, as even he said, and when he started getting a lot of pushback, nursing homes are required to only accept and retain residents for whom they have enough staff, for whom they have enough supplies to provide appropriate care. And I talked a little bit about the infection and prevention protocols. And what I'll tell people, from Congress down to a local reporter is, I didn't expect, as an advocate, I didn't expect that nursing homes would have enough PPE for a once in 100 years pandemic. I get that. But nursing homes have been required, staff have been required to know how to use PPE, to know how to stop infections. The way that COVID spread, we all know, is very similar to colds and to influenza, which facilities deal with every year. It's breathing on one another. It's touching faces and eyes to other things. And nursing homes had no excuses. Let me rephrase that. They had certainly no excuses when it came to neglect of residents, which we saw so much of, weight loss, residents that stopped responding, residents that were given inappropriate drugs. There was never any excuse for that. There were certainly cases where facilities did the best that they could and were appropriate. And even then, COVID came in. But there's been studies after studies, including a new federal study that came out about a month ago, that showed that facilities that had higher staffing did better. Facilities that had better training, that had better star ratings, did better. They couldn't prevent COVID-19 from coming into a nursing home once it was in the community, but they could prevent it from spreading throughout the facility. So nursing homes always had 100% responsibility for meeting the needs of their residents. There's absolutely no excuse for that. And they had large responsibility, but there were certainly times when it was beyond their control with COVID-19. But the issue with these directives that we've seen for immunity is that they go beyond that. I mean, a nursing home can always explain that there were extenuating circumstances. They didn't need the state legislature and the governor to give them a free pass to do as little as possible.
Thank you, Richard.
Sure. Any other questions or comments? Okay.
Thank you.
Oh, sure. Do you want me to? I'll leave the meeting then.
Oh, it's up to you. We're about done. We've got like 5 minutes left. I'm just going to review our topics here. So.
Okay. Well, thank you very much for inviting me. I appreciate it. I hope it was useful. And again, you're free to use our resources, and we're always developing new ones. And so I hope that they'll be useful to you. And I hope. Sorry, I went for a very long time, but I hope that it was useful for you all too. And
Absolutely.
Thank you again
Well,
for inviting me. Sure. Bye-bye now.
And we'll make sure we share those resources with everybody on our follow-up email tomorrow. So you guys keep
Awesome.
an eyeball on your email. We'll be sending that out. We'll have Jay work on that first thing in the morning.
Thanks,
so I just
Jamie.
wanted to thank you.
Bye-bye now.
Our upcoming meeting topic. So our next meeting will be on July 27th. Linda Shoemaker, she did a wonderful presentation for us before. She's going to come back and present some on combating the social isolation. And she's going to hold an open forum for the family members. So you can ask her anything. She is a professional. She's has a lot of dementia experience. So please feel free to bring your questions in 2 weeks to Linda Shoemaker. She'll be here to help answer those. And on August 10th, we're going to hear from Attorney Presser. She's going to explain the differences between power of attorney, healthcare representatives, living wills, trusts, guardianships, and long-term care planning and medical assistance. So that's going to be a really good one as well. And then to round out August, we're going to hear from our peer residents again. They're going to answer some questions and share their experiences living in long-term care facilities. So we have a fantastic lineup coming up. And as always, thank you for attending the meeting. Any specific concerns or complaints, please contact the State Ombudsman Office at 717-783-8975 or email us at ltc-ombudsman@pa.gov. And thank you for joining us, everyone. I hope you have a great evening. Stay safe out there. I know we're getting some pretty big storms here, so take care.
Bye, guys.